let's move to the next presentation that regards to the use of imaging when dealing with DCB-only PCI. And now we will discuss about the dissections, but I think that we fully agree on good dissections and to use the DCB. So, when thinking of using intracoronary imaging, when you are planning to do PCI with a DCB, I start thinking, okay, can we translate the evidence we have already from the DES using the imaging in the DES complex PCI to the DCB-only PCI? And then there are different specifics of the imaging in the DCB PCI versus the imaging used for DES. This was my first thought. And then I have a patient on the table like this one. This is an 88 years old male patient with several risk factors, complex patient, diabetic with comorbidities, nephropathy, polyneuropathy, retinopathy, dyslipidemia, hypertensive, atrial fibrillation requiring ACOTs, syncope that was due to IV block and then requiring a pacemaker, other comorbidities, critical stenosis, chronic kidney disease with glomerular filtrate less than 30, and also due to this syncope, the patient had a supraanioidea hemorrhage, but now is recovered at that time. But this is a complex patient, we all agree on that. And finally, the patient came to our cath lab because had an non-STEMI, angina at rest, troponin peak 3000, and pacemaker rhythm on the ECG, preserved ejection fraction, and you see the blood sample with creatinine 2.27, glomerular filtrate as mentioned 25. So this is, of course, a patient fulfilling all the high bleeding risk features, as you know, this classification by ARC, and at least this patient has 2 major and 2 minor risk factors for high bleeding risk. So what to do in this patient? We perform the angiography. Fortunately enough, the right coronary artery diffuse disease, but nothing special. Left main, okay, so minor plaque, and circumflex, okay. But the problem was in the mid-segment of the LAD with a long diffuse calcified plaque. You see here more on imaging. So then, what is the strategy for this patient? In summary, this is an older patient at high bleeding risk, long diffuse disease in a relatively small vessel, 2.75, plus minus, less than that, chronic kidney disease, and of course calcified plaque. So this is a classical scenario. You don't want to implant a stent by definition. And then you may start thinking of going for a DCB PCI, DCB-only PCI strategy. So, but then when we think of a strategy of a PCI, this patient, if you want to implant a stent, we have data by using IVUS or imaging in this type of patients, and we have data coming from the IVUS XPL randomized trial, showing that when you performing long lesion that this one IVUS, you end up with better results as compared to when you go with just angio-guided. But it's not it's not just that you do IVUS, you perform IVUS. It's also that you perform IVUS and then you obtain good result. It's not that you perform IVUS that you cannot reach the goal of optimal result. In those patients with optimal result, the outcomes are much better than in those patients, regardless using or not the IVUS, you don't get optimal results. And this is the 5 years follow-up of this trial, showing the same important feature, that in patients with IVUS guidance, you end up with better results, and these results are even increasing over time. It's not just you get the immediate result, but also a long-term follow-up. But again, if in those patients with better results or optimal results by IVUS, you end up with better results. We have another trial, the ultimate randomized trial. Again, the same concept. Optimal results with IVUS end up with better outcomes as compared to suboptimal PCI with IVUS or angiographic guided only results. So it's not that you have to use IVUS, but you have to get optimal result. You have to interpret the IVUS and use it accordingly. This is the 3 years follow-up of this trial showing this incremental benefit of IVUS guided versus angio guided. There is a long-term follow-up, an incremental an increase in target vessel failure in both arms, but higher rate in the angio guided. But in the IVUS guided cohort, those with optimal result show less increase in outcomes, in bad outcomes in target vessel failure as compared to suboptimal result in the IVUS cohort of patients. And when we pull these two trials, this is in patients with long lesions. So in long lesion like the one I presented, we pull the pool analysis of these two randomized trials, IVUS XPL and ultimate trial. You end up with better results with IVUS showing reduction in cardiac death or less cardiac death and less a composite endpoint of cardiac death, MI, or stent thrombosis. We have, and you know also, that sometimes we have also results that do not support the use of IVUS in complex lesions, and you have the IVUS chip, recently presented and published in the New England, showing that the IVUS-guided PCI in complex lesions, including those we have just presented, was not superior to angio-guided PCI. So this was really for all of us that we believe that the IVUS increases or improves the outcomes, really was quite discouraging. But probably there were some reasons for these results, starting with experienced operators that may end up with the same results if they are experienced operator with imaging, etc. But these are also the counterpart of this imaging in a complex PCI. What about DCB? Do we have evidence by the use of imaging in DCB PCI? We have this trial. This Ultimate 3 trial is a small trial, 260 patients, randomized to angio-guided DCB angioplasty versus IVUS-guided DCB angioplasty. So both groups, DCB only, angio-guided versus IVUS-guided. And the endpoint was a surrogate endpoint in stent late luminal loss at 7 months after the procedure. So those patients in whom IVUS-guided was performed, IVUS-guided PCI was performed, they show less late lumen loss at follow-up. So an improvement in the angiographic parameters of restenosis. So this is the evidence we have in the context of DCB PCI. And then we had interesting data coming from other trials that I think that worth merit being discussed here. This is Transform 1 trial. Transform 1 trial compared to DCBs, Sequence Please, paclitaxel-based DCB, versus Magic Touch, sirolimus-based DCB. But they use different ways of selecting the balloon based on imaging. The Magic Touch selected the balloon used to be used during the PCI, referred to the distal reference. So the idea was that the diameter has to be, if the diameter was has to be selected based on the diameter at the distal reference. So this is something maybe to avoid dissection, but then they end up with smaller balloons than the sequent please. The sequent please was based with the mean reference lumen diameter between the proximal and the distal. So more accounting for the tapering of the vessel. So then with Magic Touch, they end up with a 2O balloon, for instance, for the same vessel diameter, the same vessel than the sequent please was 225. So this is a first methodological issue that may explain a difference in the results. The results overall favor the use of paclitaxel coated balloon, the sequent please, compared to the Magic Touch. The late lumen loss was smaller. There was a 53% of patients showing late lumen enlargement. And dissections, this was a comment before, showed a favorable, so the presence of dissection showed favorable outcomes. In the arm of sirolimus coated balloon, late loss was higher, less late lumen enlargement, and the fate of the dissections were really unfavorable. So in the end, Magic Touch failed to achieve non-inferiority in this trial as compared to the sequent please. And this is the influence of the dissections. You see here the association with the volume of the dissection and late lumen loss. In blue, you have sequent please, in red, Magic Touch. So the longer the higher the dissection was, the lower the late loss was. So that meaning that the dissection favored the use of paclitaxel coated balloon. But this was not the case for sirolimus. And you see here also the percentage of patients showing late lumen enlargement by the use of paclitaxel as compared to less percentage of patients by the use of sirolimus coated balloon. The dissection index that can only see demonstrated by IVUS is relevant, and this is a paper from Yamamoto defining the dissection index, which is the sum of each dissection point every 1 millimeter divided by the lesion length. But there was an association with between the dissection index and the percentage of volume change. So the more dissection you get, the more increase in vessel volume and lumen volume you get, meaning that the late lumen enlargement may be associated with the dissection index. So then, coming to the Christoph comments, dissections are good to maybe to help improve or help increase the lumen of the vessel during follow-up. Then again, this was also already mentioned by Neus before. The role of medial dissection is good, and is so the best combination in this trial is the presence of medial dissection and the absence of an arc of calcium more than 180 degrees. So this is the orange line showing the less target lesion failure rate in this study. So again, this is only observed by imaging. So, and there is finally a trial, but only in the design phase, the DCB-IVUS trial, that will randomize almost 1,000 patients, IVUS guided versus angio guided, only in DCB PCI study. In the IVUS guided, IVUS will be performed before and to define the lesion preparation. After vessel preparation, also IVUS will be performed, and also after DCB application, which is also a matter of discussion, whether to use IVUS at the end, at the very end of the treatment, or just before applying DCB. And in the angio guide, of course, IVUS will not be performed. We'll see. This trial is a Chinese trial we'll see how the results will appear in the future. So then, let's go to the consensus document regarding imaging in the DCB era. This was also mentioned, but I want only to highlight the intravascular imaging. You have here intravascular imaging to be used, and this is based on this randomized trial, for optimal lesion preparation before DCB, to understand what's going on, the type of material and devices you have to use to have a good vessel preparation. This is a comment from experts showing that the media dissection may facilitate the drug delivery and then the drug transfer, and then can be used to apply DCB, or not to apply DCB and may go to for the stenting. But there is no criteria regarding the DCB optimization. So still a lot to do to understand how the intravascular imaging has to deal with the results, or the results of the vessel preparation. Good for the preparation of the vessel, not that clear when the vessel is prepared to define a good result or not. This is the Japanese consensus, and the imaging is encouraged for optimal lesion preparation again, and also to the assessment, and again to see whether there is a medial involvement or hematoma, because if you may have an hematoma, intramural hematoma, visualized by imaging, this could be the case for either fenestrate that or put a stent. But if you have a medial dissection, that could be the good way for a good signal for a DCB. And then I found this consensus from the Thailand, the Cardiovascular Intervention Association of Thailand, but it also is very interesting. Again, you have the IVUS, the imaging for a vessel preparation. Again, post-preparation to see the medial dissection that is desirable. For sizing DCB, take into account not just the distal, but also the mean between distal and proximal segment. Try to find this to cover the entire segment, and then to choose the closest diameter and round out a little bit. And then the final evaluation, this is a good dissection, there is the no hematoma, this is also the good signal. If you have hematoma, then it's better not to go for a DCB. So let's finish with what I did in this case. I went for a DCB strategy. The idea was to do good vessel preparation with the scoring, cutting, IVUS guided PCI. And then in this case, I use a sirolimus routing balloon. And otherwise, if we don't get this nasty dissection, 3-3 flow or residual stenosis less than 30%, I would go for a stent. Otherwise, I would keep with a drug-coated balloon. So I started with a 7 French guiding catheter. When you see the waist of the balloon, I could not cross IVUS in that at first choice, which was my initial idea. Then I did a small balloon dilatation. I saw the waist, and then I decided to go for a rota. This is a good signal. Then I perform IVUS after rotablator, and then you see the distal small vessel with plenty of calcium plaque, of course, 180 degrees. Some cracks there at 2, there, more calcium there, but it's a long lesion now coming aside branch at 7, more the proximal part with some cracks at 5, etc. So with this, clearly this is a big, a long calcified vessel. And you see that, you know that when you plan to put a stent in such a vessel, probably the outcome wouldn't be that good. So we made some measurements, the discrepancy between proximal and distal, references, etc. You have a very small vessel distal and and a bigger proximal. Then I keep predilating with a non-compliant balloon and several dilatations, and then I obtain this angiographic result. You see TIMI3 flow, good less than 30% of diameter stenosis, but let's call it a nice dissection in this mid-segment. And this was the question. This was in a live case, and then I asked the podium what to do, stenting or leaving alone. And then I went for a DCB. I decided to go for DCB, that I thought that was a good result after vessel preparation. And then it was a 2.5 40 millimeters long drug-coated balloon. And this was the result at the end. Nothing changed, apparently. And this is with the wire. I wait for a few minutes, and then this stayed as it was, and I decided to leave it alone. And the patient was discharged and eventful with triple therapy just for 7 days, then keep just one P2Y12 for 6 months and a PIC7, and then now it's 9 months after the procedure, and the patient remains asymptomatic with no problems after all. So my take-home messages regarding the role of intracoronary imaging in DCB-only PCI is that intravascular imaging plays a role in the pre-PCI assessment and post-preparation lesion evaluation. Medial dissection has been associated with better performance of DCB. However, no evidence-based intravascular imaging criteria have been established for DCB optimization up to date. So it's a lot of work to do in the coming years in this regard. So thank you very much.